Welcome to HealthAide Chats. Today we have Mr. Kieran Richardson. Kieran, thank you for your time. I'm very excited to speak with you today. Can you just describe to our audience a little bit about yourself and what you do, please?
Yes, so I work as a specialist physiotherapist. So in Australia, we have different tiers of training. So you can start off as a graduate physio, and then you can do a master's degree. So I've done additional training post my master's degree. So basically, I work as a non-surgical specialist in private and public settings in Australia, and I also offer consultations for patients around the world. Aside from that, I also train healthcare professionals. So I see patients still, but then I do a lot of training in professional development with people both locally, where I'm based in Perth, Western Australia, but also over east, the other side of Australia, and internationally. It's a lot of fun. Yeah.
Excellent. Kieran, so one area of interest for you is the evidence-based non-surgical management of ACL tears. Just briefly for our audience, can you explain what the role of the ACL is and typically how does an ACL injury occur?
Yep. So that's a very big question, but I'll try and answer it simply. But basically, the ACL, you might have heard about it, the anterior cruciate ligament. It's one of the ligaments inside your knee, and it's got a job that has, it's essentially its role is to stop the knee excessively twisting or the shin excessively moving too far forward on your thigh bone. And you would, if you follow sports, it's often a sports person's injury. So they'll most regularly it's injured when someone pivots. They kind of twist on their knee and go to change direction, and their knee will feel like it gives out on them, and they may hear a pop and get associated swelling, and can be difficult to put weight on it. And then at the elite level, you'll often see the players devastated because there's this assumption that they may need surgery. And a part of what I've been doing with patients, particularly in the past 5 or 6 years, but since I guess the COVID crisis, coronavirus, I've been doing a lot online where we work with patients and often with their surgeon, and we're trying to work out whether people actually need surgery or not. And a lot of the time they don't. And this is obviously fantastic news for patients and really good for the healthcare system, and we can save a lot of money. Obviously, physiotherapy is a heck of a lot cheaper and less invasive. And obviously, there's people that are going to need surgery, but it's just trying to work out who does and doesn't need it. And so, yeah, I spend a lot of my working week working with patients and then training healthcare professionals on this topic. Yeah.
That is amazing, Kieran. So I guess based on your research and your experience, like, are there any identifiable risk factors for an ACL injuries? It's a big question as well, I know.
That's also a very big question. There is. So being overweight can be, being young can be. Certainly one of the biggest risk factors is female gender. So they're at significantly higher risk of injury. Playing pivoting sports, obviously, but I have had patients where they may just step down wrong from a curb, and that can cause the knee to give out on them. But there's some of the main ones that you'll see, and some of them are modifiable. Not engaging in a prevention program is one of them, and so that's something I'm also quite passionate about. But so if you are engaging in a prevention program, obviously that's going to reduce the risk. Well, they're actually technically called injury risk reduction programs because they never fully eliminate. There's always going to be a risk of injury, but if you aren't participating in them, then you have a significantly higher chance of not just injuring your ACL, but potentially other injuries in your knee if you're playing sort of at risk sports. Yeah.
Yeah. So even, for example, for like the recreational athlete or for the average person who's really never had a knee injury and they're doing some kind of activity or sports, it's really useful for them to undergo one of these risk reduction programs, isn't it?
Absolutely. Yeah, absolutely. It almost should be mandatory at a club level, at a general population level, that if people are participating in leisurely type sports, even, tennis, these sorts of things, but particularly team sports and higher level sports where there's change of direction involved, it should be mandatory And if even if you're not necessarily doing that, it's a great thing for your health to be participating in these types of exercises. But it's people just don't necessarily know about it.
Mhm.
And it's kind of like this, they don't know that they don't know. So it's this unknown. And so part of, I guess, what I'm trying to do is, and working with HealthAide is to try to bring this awareness of very simple strategies that you can use that patients can adopt, and clients in the general population, that can be used simply, quickly. They're not painful to do or anything. It's efficient, and it can be, we know from research studies it's highly effective.
Yeah. So what would one of these injury reduction program kind of look like, if you were to explain it briefly?
Yeah. So basically you have, to explain it briefly, you would have at least a couple of times a week, you would spend 10 to 15 minutes doing various forms of exercises on your lower limbs. So some of them are strength-based, some of them are balance-based, some of them can be like modifications of various hopping and jumping exercises. And you can start them certainly at someone who's young, or someone who's middle-aged, or someone who's older. They're pretty easy to start doing on your own. And you can always seek out additional advice if you do have any issues starting them. But generally it's pretty, there's some structure to it, and then it's something that you would just maintain, ideally lifelong. And that's a general overview.
Excellent. So if a person's listening to this and they're just sustained like an actual or suspected ACL injury, in your opinion, what is the best thing for them to do right away?
Yeah. So the best thing is to not panic. So a lot of people will panic and stress out and start to worry about their future, and there can be this inherent belief that surgery is the only option. And so I would say that firstly, just don't panic. I encourage people to seek out sound advice from multiple practitioners. It's good to have a team involved. So rehabilitation expert, someone who is experienced and trained in managing ACL injuries. It's highly advisable to commence some exercises. And again, it's difficult to comment because they can be very specific to an individual. But I would say most of the time, it's been shown in lots of different studies that by starting exercises, whether you ultimately end up not having surgery or you have surgery, starting exercises, or prehabilitation we call it, the patients will have a far better chance of having a better outcome long term if they do that. So that's super important. And just to consider your options is probably a third thing. So you have options available. It's not like you have to rush. Some people feel like they have to rush out and choose the first option, which at least in the Australian context or the US context would be surgery. But it's normally, and the current research evidence would suggest that often is the last option that we want to choose. And that's not just specialist physiotherapists that are saying that. That is, a lot of surgeons would advocate for that, depending on the patient. And so, this is something those are some of the key things that I would encourage people if they've just injured their knee. Yeah,
excellent. I guess really the important thing is that there is a growing body of evidence to know that people with an ACL injury can cope without needing surgery, right? And that is the big thing you're trying to push. And we kind of call these people, you say you kind of call these people who can cope without surgery copers, and those who kind of are non-copers. So kind of at this moment in time, is there a way for us to assess whether someone will be a coper or a non-coper early on?
Early on, no. So basically, the terms copers and non-copers is kind of a US term. Mm-hmm. I do think it's probably a bit of a false dichotomy. So we definitely can't say early that someone's absolutely going to be a coper or a non-coper. We kind of don't know. So it's scientific in the sense that with each person that gets injured, we kind of have to test and see and try to work that out. And it is based on the current research, it's essentially impossible to, it's no one has a crystal ball, so we don't know. And there is new research showing that ACL tears can heal in some patients. So that is, makes it further challenging to try to say that someone may or may not be a coper, because we have studies where the ACL clearly hasn't healed, but the patients have no symptoms. And then you have some patients who have evidence of healing, but they may still feel like their knee is going to buckle or feel unstable. And so it's difficult to work that out, in the first few days. You'll never know, because we don't know if the patient hasn't undertaken a rehabilitation program. So yeah, I the terms copers and non-copers is what it will often be used, but I just would sort of say, it's more like a time frame thing for me. Getting the patients, they know they've got all these options. They can commit to 3 to 6 months of pretty intense, specific, supervised rehab, and then they can always make the big decisions for surgery or not, at that time point.
Yeah, I guess there's a lot of uncertainty. I think that is something that we can continue to learn as we go. But the one thing, from what I'm understanding, that's certain, from my understanding now, is that prevention, undergoing a risk reduction program, is really, really important for prevention, and we know that for sure.
Absolutely. So and we'll talk about this in the lectures, the lecture and tutorials that I make for patients. But basically, it's categorically proven that these, the best thing is to not injure your knee in the first place, and you can categorically reduce the risk of having a knee injury by engaging in these prevention programs beforehand. And we're talking big numbers, like at least half of them. Some studies would suggest up to 75% don't even ever need to happen, which is amazing. But a lot of people don't do them. The majority of people don't do them. So this is a key thing that we're trying to get out there and show patients that and the general population, so they wouldn't even necessarily be patients, but it's something that they should be doing, almost like you would brush your teeth or, get dressed. If you're going to engage in sport and exercise, it should be something you should do.
Yeah. So really, apart from like preventing an ACL injury and affecting your sport or daily life for the next 12 months, like you alluded to, there are benefits of doing this kind of prevention program. What are some other benefits that you've seen?
Well, I think there can be some crossover to actually the person's ability to perform. So depends on the patient again, but by engaging in some additional strength training and balance work and dynamic strength work, it may also help your performance. That'll depend on the individual, and there'd be some suggestions of that. But I would say that's pretty crucial. So there's the probably the most important thing is that it would reduce your risk, but then you have these additional benefits that it may help you play better, feel better, maybe might make you feel less pain. It just really depends on the patient, on the person.
That's good. And I get asked a lot myself in the clinic, is that when someone's done an ACL or they had an injury like that, is there any long-term risk that they've already had done to the knee?
So if you do sustain an injury, there's an increased risk that you will have arthritic change in your knee, but you may not necessarily ever feel any pain after the injury is settled. So there is an increased risk of you having arthritis. That is true following the injury. So there's less risk of having arthritis for doing these prevention programs if you follow that rule of logic. But you may not necessarily feel pain associated with that. So some people get really, I've got a patient, she just emailed me before, and she was worried about, I'm due to see her for a first consultation next week, and she's worried about whether she'll have arthritis. And I'll be answering her and say, look, there's an increased chance you'll have arthritis, but you may not ever feel any pain once you've completed your rehabilitation program. So that's the short answer.
Okay. I guess from my, if I ask you a selfish question, from my personal experience, I've had a full thickness ACL rupture in 2013 playing basketball. At the time, I was only offered surgery option, so which I underwent, and I went through 12 months of rehab, which now 9 years later, my knee is great. But when I returned to basketball later on, like even though I didn't have any instability and strength was good, I just had a sense of like fear or lack of confidence. And I see that very commonly among my patients as well. So number one is this problematic, and how would you go about addressing this?
Yeah, it's very common, highly common, and a lot of patients will in fact never return to sport. So this is one of the problems with the surgery. Doesn't necessarily give you a golden ticket back to sport. Depending on the paper you read, there may only be 50 to 60% of people that actually ever get back in the general population, and they a large portion of them don't get back to the same level they were at. So that's important to know. But you do get a lot of patients that they call them an adapter, which basically means they choose not to return to pivoting sports, whether they have surgery or not, because they worry that they might re-injure their knee. So what you described about the fear of re-injury is very common. And there's some argument that, in fact, the psychological factors associated with your knee, how you think about your knee, whether you feel like it's going to cope with sport, do you trust activities with it, your confidence in using it, all those factors are almost better predictors than the physical function of your knee. So if we test your knee physically in the clinic, it's maybe not as good as if we ask you questions about your knee psychologically. So for sure, I see that. In fact, it's every single patient has it. It's just to the extent of how much it's affecting them. And so I try to, had a patient just today from another country, and, over telehealth, and I've actually engaged a sports psychologist for her, which I almost never do, but it's become a very big issue for her. High fear, very worried, and she's going very well physically, non-surgically. So I think it really is a case by case. It's a case by case thing here with that, William. But yeah, it's always something we have to look out for.
Okay, so I think if for example, I had access to your information and a program that you described, I think, going back, I probably would have prevented or reduced my risk of having an ACL injury. And I guess if I have the knowledge now, that I would have delayed my my surgery as well. So it's really useful. I say thank you for what you're doing, and I think it's really useful to really keep pushing that for everyone out there. But
yeah,
I guess
it hasn't been. It's always tough bringing something new, and not everyone's going to accept it. But then I haven't had, honestly, very few people regret waiting and assessing all their options. I think it's a good way to think about it. Like, I heard one podcast the other month, and the speaker was saying, look, if we were to go buy a house, you wouldn't just make a decision on a whim. Well, very few people would make a decision on a whim. You would ask lots of questions, you'd gather all the information. And I think it should be the same with our own bodies, but not everyone thinks like that.
Yeah, I guess one thing I hear is that when we delay surgery, for example, we do 6 months of rehab, and then you find that they need surgery. Does that then delay the whole process? Does that mean they're going to have 6 plus 12 months later on?
Not really. I mean, it in some ways it could be. Patients might feel like that. But then again, as we said earlier, we may not know whether they were going to be a coper or not. And they're typically their knee will be better prepared for surgery anyway. And the other thing we have to consider, it sounds like you had a great outcome from your surgery, which is good, but surgery doesn't always work. So just because the physio doesn't work doesn't mean the surgery is going to work. And so we have this, if we use that coper phrase, there's some patients, if they're not ready at 6 months, but you give them up to 12 months, they become ready. So there's lots of different factors to consider. And I think some patients will choose surgery because they feel like they don't want to run the risk of non-surgical failing. So they will just choose surgery psychologically early, which I can understand and appreciate. So I think it's a case of the patients having all those options and knowing what the risks and benefits of each pathway is, I would say.
Thank you, Kieran. Thank you so much for your time. Look, I think we'll leave it at that. Is there any closing comments, or where can people find you and your online courses and your contacts?
Yeah, so people can feel free to follow me on LinkedIn personally. I've got quite a decent following on there. You can follow me on Instagram, global_specialist_physio. That's been quite popular of recent times. And also my website's globalspecialist.physio/ACL. And there's lots of patient stories on there, free resources, got some of my courses on there, which patients can do and clinicians can do. And they can access consultations with me over Zoom, which I've done thousands in the past couple of years with COVID. It's just taken off. And I think it's a lot of these things you can talk through with patients, and even just the counseling, I think, is really important.
Okay, excellent. Thank you so much, Kieran. We'll talk to you later. Thank you.
Cheers, William. Nice to see you.
You too.